My name is Danielle Walker, as I've said. I'm from BreastScreen Victoria. I'm a health promotion officer there, and thank you very much for having me here today. I'm going to talk a bit about priority populations or underscreened population groups in the BreastScreen program and some enablers to encourage participation. I'd like to start by acknowledging the traditional owners of the land on which we meet and pay my respects to their elders past, present and emerging. So today I wanted to give a bit of a refresher on breast cancer in, it says Australia, but I'll focus on Victorian statistics. I'll provide a bit of an overview of the BreastScreen Victoria program, including eligibility and the BreastScreen pathway. We'll look at some of the barriers that the general population face when it comes to breast screening. We know that the participation rate for the BreastScreen program is 54% of the eligible population. So we'll look at some of the reasons why the other 46% don't screen. We'll discuss and look at some of our underscreened population groups. There are 6 identified underscreened groups, and we'll go through individually as to some of the unique barriers that those groups face to screening. And also, I'll then outline some practical steps that can be taken specifically in the primary healthcare setting to increase breast screening participation rates. So, breast cancer is the most common cancer found in females. In 2017, which is the most recent data that we have, there were 4,555 cases of breast cancer diagnosed in that year. And the Australian Institute of Health and Welfare have actually said that this year, for the first time, breast cancer will become the most commonly diagnosed cancer, overtaking prostate cancer. It's a common cancer. 1 in 7 people will be diagnosed in their lifetime. However, 90% of these people survive. So when you actually look at a graph or you consider trends over time of incidence and mortality, the number of people who are being diagnosed is increasing and has been since 1982 when we started to collect data. It gradually is increasing, but mortality is gradually decreasing. So it's increasing because of population growth and an ageing population, but decreasing because of increases in technology, increases in awareness. We talk about these things more, and of course the BreastScreen Victoria program. As I'm sure you all appreciate, early detection is vital. The earlier we find breast cancers, the greater success of treatment and recovery. The 2 greatest risk factors that affect everyone equally when it comes to a breast cancer diagnosis are being female and getting older. Unfortunately, there's not much we can do about either of these things. We know that 75% of breast cancers are found in women over the age of 50. I'm sure you have heard of breast cancer being found in males, but it is rare. Less than 1% of all breast cancer diagnoses are found in males. Family history can increase your risk of developing breast cancer, but only 5% of people who are diagnosed have a strong genetic link. So it's more likely that if someone in your family has been diagnosed, it's just because it is a common condition. And I'll talk more about this on the next slide. There are some things that people can do to reduce their risk of developing breast cancer, and these are things that people hear time and time again. We can eat a healthy, balanced diet, participate in regular physical activity, quit smoking, and reduce alcohol consumption. Cancer Australia produced a report about a number of different risk factors for developing breast cancer. And it ranges classifies, I should say, the risk factors from convincing evidence to inconclusive or no association determined. I personally find this information very interesting, and they've put together a website which is breastcancerriskfactors.gov.au. It's very consumer friendly. People can just type in the risk factor that they're concerned of and see where the evidence currently lies. And I do have a copy of it all here. If you are interested, I'm happy to show it to you. Breast awareness. So we do encourage people to be familiar with the normal look and feel of their breast tissue at all ages, to be able to notice any changes that could be an early sign of breast cancer. We know that 30% of breast cancers are found outside the BreastScreen program, what we call interval cancers. So they've found it themselves or noticed a symptom and had a discussion with their doctor about it. And when we talk about looking for breast cancer symptoms, we are of course talking about any change to the shape or size of the breasts, any change to the breast tissue such as lump or lumpiness, any changes to the nipple such as discharge, any change to the breast skin such as a dimpling, or any unexplained pain that doesn't go away. What we suggest is that if any woman experiences, well, anyone really, if anyone experiences these symptoms, that they see their GP immediately, because they can be then referred on for diagnostic testing. So as I mentioned, a small number of people are at an increased risk of breast cancer because of family history. And basically this picture just shows that in picture format. So out of 100 people, 95 will be at an average population level risk, 4 will be at a moderately increased risk because of family history, and 1 will be at a high risk. Now what I wanted to point out are these 2 websites. So these are great tools, one for patients and one for health professionals, at helping to, I guess, obtain an informed decision about family history and risk of breast cancer. So the pdmac.org.au/iPrevent tool is great for consumers. So it steps them through about a 30-minute questionnaire where it goes through questions about blood relatives that may have had breast or ovarian cancer. And it produces a report that they can then bring along to their doctor to have an informed discussion, considering individual risk factors around that. For health professionals, Cancer Australia have developed the Familial Risk Assessment Breast and Ovarian Cancer Tool, which is shortened to FRABOC. You may have heard of that one. It provides an estimation of the risk of developing breast or ovarian cancer based on family history for women who haven't had a previous diagnosis. It's specifically targeted for GPs and nurses, and it can help health professionals to reassure the majority of women who are at a population risk, who are at that 95% or in that 95% group. And it also can help to identify women who should be referred to a familial cancer screening service. So, BreastScreen Victoria is part of the National Cancer Screening Program, and it was established in 1993. We provide free 2 yearly mammograms to women over the age of 40 for the early detection of breast cancer. We say that we can detect breast cancers the size of a grain of rice, so before they can be felt or noticed. And as we all know, early detection is critical. The appointment takes 10 minutes. It's always with a female radiographer. People don't need a doctor's referral or a Medicare card to attend a breast screen appointment. And we have 42 clinics across the state. We also have 2 mobile screening vans that travel to rural and regional areas of Victoria to provide the exact same service to women who wouldn't otherwise be able to access that. Specific to the Western Victoria Primary Health Network, we have clinics in Ballarat, Geelong, Warrnambool, Portland, Horsham and Hamilton. Our mobile screening van visits Corio, Cobden, Warracknabeal and St Arnaud, and other clinics nearby include Bendigo, Maryborough and Birchip. So who should screen? And there's a lot of confusion around this, so hopefully I clarify things if you're not already aware. While women over 40 are eligible to screen in our program, we encourage women aged 50 to 74 to screen every 2 years. And when a woman turns 50, we will send her a letter inviting her into the program. And we get those details from the electoral roll. For women aged 40 to 49 and over 75, they are eligible. However, we suggest that they chat to their GP first to determine whether breast screening and mammograms are effective or the most effective option for them. Because research shows that mammograms are not necessarily the most effective way to detect breast cancers in that younger demographic when the breast tissue is more dense. It can be harder to see any changes on an X-ray. Our program In terms of communication and engagement with women, it ends at the point of definite diagnosis. At that point, they are then referred back to their GP or breast specialist for treatment options. So, in our program, once an appointment is made, they are sent a registration and consent form. They bring that along to the appointment. We take 4 images, 2 of each breast, so 1 from the top and 1 from the side. Compression is applied to the breast. We often hear that it is uncomfortable. It should never be painful. We do encourage women to speak up. If it does become too painful, they can tell the radiographer to stop, and we can look at relieving some of that pressure. After the appointment, the results are sent to the woman as well as the GP if elected within 2 to 4 weeks. If everything is A-OK, we'll invite the woman back 2 years later for her next screen. For a small number of women, we will recall them for further tests and assessment. 6% of women who do screen will be recalled for further investigations. Most of the time, it's not breast cancer. We just want to be sure. We may have seen a change from one screen compared to a previous screen, and we just want to investigate what's going on. So we'll recall her for assessment, and as I said, most of the time, it's not a cancer. As I mentioned at the start, breast screening participation rates in Victoria are 54.1% of the eligible population. And when I say eligible population, I mean women aged 50 to 74. In the Western Victoria Primary Health Network, participation is above the state average at 58.7%. And I've broken down the LGAs within the PHN and their screening rates. And I guess the most obvious observation you can make for this is that where we have clinics, so in Geelong, Ballarat and Warrnambool, the screening rates are higher. So the role of the health promotion team, of which I'm a part of, is to raise awareness of the importance of breast screening. It's to raise awareness of breast awareness, encouraging women to be familiar with the normal look and feel of their breast tissue, and also to promote and encourage participation in the BreastScreen program. And we do this in a number of ways. We offer free information sessions to community groups. We do presentations to workplaces, because we know that, and we'll see more of this later on, that the competing priorities of work and life commitments is one of the major barriers to screening. We can attend expos and events with a table, hand out resources and have chats to women. We coordinate an ambassador program, which allows women who have had experience in our program to really just promote it amongst her community members. And we also work with pharmacies and other health professionals to raise awareness. So with a state average of 54.1% participation, there's obviously a large number of women who do not participate in the program. And I should just quickly mention as well that some women do choose to screen privately, and we don't know what those rates are. So we can't assume that everyone doesn't screen, and we'll never know who does screen privately, but that is just something to keep in mind when we're looking at participation rates. So in terms of increasing participation, obviously we need to look at some of the reasons why people don't screen. What we do know is that 37% of women don't return for their second screen after their first screen. And for those that do return for their second screen, 25% don't return for their third screen. When we then look further along the screening pathway, it really does increase in terms of participation. So key is to get women early and to get them really positive and positive behaviours around screening, and encouraging them early from the age of 50 to participate regularly. At the end of 2018, we undertook a survey of people to find out why women don't screen, but also just general perceptions around breast screening. And 484 people responded. We found that when booking that initial breast screen, a letter from us when they turned 50 was the key driver to book that initial screen, but then a recommendation from a medical professional and a recommendation from a friend or relative or colleague were other key prompts to book a screen. When then looking at why women didn't book their second screen, not getting around to it or not making it a priority was the key reason, along with a change of address or not receiving a letter, which probably are the same thing. They may have changed address and then not received a letter. Other reasons why people didn't come back, and I just wanted to highlight some of these because I found them quite interesting. Breast screens are too painful, having a negative experience at a previous screen, access, not believing they are at risk of breast cancer, not knowing they had to have another screen, not believing that breast screens are effective at detecting breast cancers, and some people said they were afraid of getting a breast cancer diagnosis, so it's better not to know. When looking at general perceptions of breast screening, which is something else that we asked them as part of this survey, we found that majority are very aware that early detection is key to successful treatment, but less agree that a breast screen is the best way to detect a breast cancer. So this really shows that educating lapsed screeners is important in engaging them back into the program. And the more understanding they have, the more likely they are to see the value that breast screens can have on their overall health and well-being. So underscreened or priority populations are those population groups that experience systematic barriers to participation in the national screening programs. And the Department of Health and Human Services Underscreened program aims to reduce the disparities in the diagnosis of early stage breast, bowel and cervical cancer through increased participation in cancer screening programs. Now, participation rates for underscreened populations, it's hard to determine participation rates because of limited data. However, what we do know is that these 6 population groups have been identified as having lower rates and therefore do experience poorer cancer outcomes. So these include Aboriginal women, women from culturally and linguistically diverse backgrounds, people living in low socioeconomic areas, people with disabilities, people that live in regional and remote areas, and LGBTI communities. And these groups experience the same barriers that the general population face to screening. However, they're often confounded by unique and specific challenges to those groups. And this may include lack of knowledge of the screening program, access issues, having other priorities, fear, affordability, stigma, and cultural factors. And I'll go through each of the groups now, and we'll have a look at some of those specific reasons for each group. So Australia-wide, Aboriginal women experience lower incidence rate of breast cancer, however have poorer survival rates when diagnosed with breast cancer. The current Victorian screening rate for Aboriginal women is 34.3%. However, this ranges when looking at different areas. So in Gippsland, it's 45%, but in areas of Melbourne, it's down to 29.3%. VACCHO, who are the Victorian Aboriginal Community Controlled Health Organisation, recognises that the key to enhancing Aboriginal health outcomes is community-led solutions. And this includes focusing on enablers rather than barriers to health services such as breast screening. Some issues that we do know Aboriginal women face and things that we at BreastScreen Victoria do need to work to address include cultural insensitivity and a lack of cultural awareness at clinics. For example, when women have an appointment with BreastScreen, we ask them about blood relatives and any family history, and the idea of blood relatives and family can be quite different to what we know. Like friends and friends can be considered blood relatives. We also had an experience where a radiographer at BreastScreen told a woman that she wasn't Aboriginal because of her skin colour. So even at our level, we need to be thinking about these things. Fear or previous negative experience, historical apprehension about mainstream health services, feeling shame at being undressed in front of a stranger, and logistics, travel, cost, kids, work. However, we do recognise that there are some enablers that we can leverage to increase breast screening in Aboriginal women, and that includes partnering with Aboriginal organisations and ensuring cultural sensitivity, so providing training for BreastScreen staff and really working on community-led solutions. And I'll talk more on the next slide about a specific project we've been working on lately. Ensuring a positive experience, ensuring good information is presented in a culturally appropriate way. Education, so providing tailored information sessions. And support, so we can organise group bookings, including transport to a BreastScreen clinic. So ways in which we are working to increase breast screening participation rates in Aboriginal women include bringing our mobile screening vans to Aboriginal community-controlled organisations. We've recently been to 8 sites across Victoria, which again I'll speak to on the next slide. The Shawls project, which I'll speak to in a second. Organising group bookings, as I said, we can organise familiarisation visits to clinics so they can see what is involved. We attend events such as Aboriginal Health and Wellbeing Days, and we work with community leaders to ensure all of this is implemented in a culturally safe and appropriate way. So we partnered with VATCHO this year to implement the Aboriginal Shawl and MSS project. In fact, the last site we visited was just last week, I believe. So the aim was to increase cultural safety and improve the breast screen experience for Aboriginal women in the 8 sites across the state. What we did is we designed a shawl, and we worked with local Aboriginal artists in each site to develop 8 different designs, and I brought a couple today. So that's one. And the woman can wrap it around her. And the idea being it provides a safe barrier that removes, some of the fear and anxiety around screening. And each woman who did screen did take it home with her. I've got some of the responses we had from the project on the screen there. So we visited 8 ACOs, as I mentioned. The sites in the Western Victoria PHN region that we visited included Portland, Haywood, Pernem and Geelong. In total, we screened 332 women, of which 159 identified as Aboriginal or Torres Strait Islander. And a key principle underpinning the success of this project was that it was a community-led initiative. It was driven by the needs of Aboriginal women, and it was driven by the ACOs on the ground. VATCHO and VARS, the Victorian Aboriginal Health Service, ensured that community control was at the centre of the project. It actually was just announced as a finalist in the Vic Health Health Promotion Awards, which is the state's highest accolade for health promotion, in the Improving Health Equity category. I just thought I'd show you a news clip that featured in Shepparton when we visited Rumballara up there, I think it was last week. And if this works.
Bright in colour and covered in the designs of a local artist, this new shawl is changing the breast screening experience for Indigenous women.
Lots and lots of incredible feedback, so women are letting us know that they do feel safe in culture, being wrapped in culture, feel visible, feel strong and feel comfortable to screen.
The garment went on display as part of Rumballara's Women's Health Day, highlighting the importance of cancer testing.
Aboriginal women's screening rates are about 18% lower than the average, but we get diagnosed twice as often.
The event's an initiative of the Cancer Council, BreastScreen Victoria and the Victorian Aboriginal Community Controlled Health Organisation.
It's really important that women get their cervical screening test every 5 years, and also with breast cancer screening, aiming to get their breast cancer screening done in 2 years.
BreastScreen Victoria's then will be at the Rumballara Cooperative until the end of the week, offering up free breast screens for women aged 50 and over. And for some, the testing can mean the difference between life and death.
Early detection is really important because if you can get it early enough, there's better chances of survival.
Grace Evans News.
And I know in Ballarat, there's also a similar initiative. Did you want to talk about that now, or is there time later?
We'll do it a bit later.
Yeah, okay.
After lunch.
Yeah, okay, no worries.
Can I, Daniel?
Yeah, of course.
Add one thing that's
Please do.
specific to the Ballarat assessment clinic.
Mm.
So women get screened and they then need to be followed up. If they're in the catchment and end up going to Ballarat BreastScreen service, there's been an initiative there that started in 2012 where if a woman is diagnosed with breast cancer, the breast surgeons who make that diagnosis at the assessment clinic can, triage the women and directly to refer them if they're using the public hospital, Ballarat Health Services, for their treatment. So that they don't have to go back to the GP to get the referral, and that just speeds up the follow-through process. Mind you, still, the GPs obviously get a letter and information and they may well see the woman anyway, but they can be referred directly. And I think that's unique to Ballarat.
I haven't heard of that before, so it must be, yeah.
Which is really awesome, and it was something that was initiated because a couple of women got lost in the pathway between diagnosis and getting their treatment, so it's helped move that process through.
Yeah, fantastic. Yeah, good example of removing that barrier, you know, that extra step. So the limited research that we do have shows that women who come from culturally and linguistically diverse backgrounds screen at lower rates than people who are born in Australia. What our participation stats show is that 45.7% of people who speak a language other than English at home participate in our program. But you need to consider this within specific language groups. So Italian, Greek and Arabic women screen at much lower rates than that, but Vietnamese, Turkish and Maltese women screen at much higher rates. For many newly arrived women, they often speak English as a second language, and they come from countries where breast screening is not an option. So we need to consider things like a lack of knowledge, fear, other priorities, health beliefs. So when we were doing some work with the Karen community in Bendigo, we found that some people thought that cancer was a curse and something you couldn't do anything about. When we were working with Afghani women, some feedback that we had was that Afghani women don't get breast cancer. And when thinking about this, my colleague said, well, unfortunately many Afghani women don't live to older ages. We also hear that some people think that Australia gave them breast cancer. They came here, had a screen and something was detected that they didn't know about before, so it was Australia that caused it. Or even talking about it can cause breast cancer, so it's best just not to talk about it. Also, many newly arrived women are not on the electoral roll, so we have no way to contact them, which is why a lot of the health promotion work that we do is so important. Some things that we do to address some of these issues include partnerships. So we're working with AIMS at the moment and organising group bookings whereby we train their case managers on BreastScreen's key messages. They then call their clients in language, explain what it's about, and then we organise a bus to take a group of women to the local clinic where we block out some time and we put on a bit of a lunch, morning, afternoon tea, and provide some more information around breast screening and breast cancer. We've trained bilingual staff at the Centre for Multicultural Women's Health to provide in-language training and information sessions about breast screen. We've also conducted calls in language to new and lapsed women. So we call them in their preferred language, and it just provides that safer, more familiar environment, I guess, to discuss breast cancer and breast screening. Appointments can be made with an interpreter on the phone, and also at an actual screening appointment, if an interpreter is needed, we can organise for an interpreter on the phone to be available. We also organise group bookings, such as with the AIMS client group, and host information sessions with interpreters. And we also have a number of translated resources. I do have some tucked away in my basket. They're just not on the table, so if it is something of interest, just let me know and I can get them out for you. So as we all here know, that women from regional and rural areas experience significantly poorer health outcomes than their urban counterparts. And this is the same with breast cancer. So evidence shows that the incidence of breast cancer is lower for women in rural areas. However, for those that are diagnosed, mortality rates are higher. We know that rural populations are less likely to attend breast screen appointments, and this is seen not just in Victoria but in Australian data and international data. Research shows that the risk of mortality in interval detected breast cancers, so those in between the 2 yearly screens, is higher in women who live in rural areas, which really shows the need for education around breast awareness at all ages. The obvious barrier that women face is access, the logistical issues and the time to get to breast screening clinics and services. Also, if a woman is called back for assessment, it can be challenging for women in certain areas. For example, for a woman who is screening in Portland and is recalled for assessment, she's required or invited to travel to Geelong. It's 4 hours away. With all this in mind, our key response to this is the mobile screening service. So there's a couple of pictures there. We travel to 32 sites around Victoria on a fixed 2 yearly schedule. Where time in the schedule allows, we also trial new sites based on demand. So we trialled Corio in Geelong and we trialled Heathcote. They're now both on the regular schedule because of the demand and the need in that area. Also, the screening site, the mobile screening van site of Wangaratta is now a fixed clinic. So we're always looking at new ways to increase access to the service. And we work with community groups prior to the van's visit to raise awareness of that it's coming. So we'll work with councils, with community health services, with GP clinics, with local shops. We'll drop off posters to put in the windows. And we also, outside of the mobile screening service, we also work with community groups. So in October it was Breast Cancer Awareness Month, and I travelled to Donald and spoke at their Pink Ribbon Morning Tea. So again, just any opportunity that we can continue to raise awareness of breast screening and the need for self-checks and knowing what's normal and what's not normal across the whole lifetime. So women with a disability are at much risk of developing breast cancer as the general population. And we are committed to ensuring the barriers that women with a disability face to breast screening are addressed. Most eligible Victorians with a disability are eligible. However, a breast screen may not be the most appropriate and comfortable option for them. And we suggest women with a disability speak to their GP about the breast screen program, because there may be some other options that are more appropriate, such as ultrasound or a clinical examination. The barriers that we've looked at already are experienced by women with disabilities, but they're often heightened. So this includes fear or embarrassment, competing life prioritising and not prioritising breast screening, pain or discomfort, and access to clinics. So we recently worked with the Cancer Council Victoria, and with them, and in speaking to women with disabilities, we found that communication barriers, in particular literacy and comprehension issues, were a major theme for women with a disability. Financial barriers and lack of knowledge of the service, that it is free. Access to GPs, competing health needs, and the need for informed consent. Additionally, some other issues include the mammogram machines not being accessible for women in certain wheelchairs. We do need the arms to be able to be removed from wheelchairs to be able to screen. There is physical positioning required, and this is not always comfortable or appropriate for everyone. The pain that some women experience on compression, it can be heightened for some women with disabilities. We invite women to screen based on the electoral roll, and not all women are on the electoral roll. We need to consider the physical access of clinics. Is it wheelchair accessible? We need 2 radiographers scheduled at any one time to be able to screen a woman with a disability. The availability of a support worker or a carer. And assumptions and stigma. Some health professionals may focus on the person's disability rather than their cancer screening needs. Most of our centres do offer wheelchair access, and our mobile screening van does have a wheelchair lift that enables women to be able to access the van. We can provide longer appointment times. A carer or a friend or family member is more than welcome to attend, and an Auslan interpreter and assistants and guide dogs are also welcome to attend. I'll see how we're going for time. Yeah, of course. I'm not sure why. That's a good question. I'm not sure why that is.
For example, my partner's Kiwi, so she's never going to get a reminder letter.
It's because, actually, women don't need a Medicare card.
Okay.
Yeah. Yes. So this in itself is a barrier for many women. If they're not on the electoral roll, they won't get that prompt. Yeah. But they are welcome and eligible because they don't need a Medicare card. So while sexual orientation and gender identity are not asked at any stage in the BreastScreen program, through assumptions of interactions with general health services, we have identified women from LGBTI communities as having lower participation rates in the BreastScreen program. In particular, Australian research has found that older lesbian and bisexual women are an underscreened group. Back in 2011, we undertook a small survey of clients and staff, and some of the experiences that we found included previous experience or discrimination can impact on a decision to screen. Some women reported receiving hostile reactions when disclosing their sexual orientation. Heterosexist attitudes, so the types of questions asked, may not be relevant or assume heterosexuality, such as assuming a partner is a friend or sister. The lack of knowledge within staff of cancer risk and screening information, particularly for transgender women, which I'll cover on the next slide. Invisibility or not being targeted in promotional materials, such as a poster within a reception area, images on websites or publications. Does it reflect the community that we're trying to reach? General myths and lack of knowledge about breast cancer within LGBTI populations, and a reluctance to come out or fear of being forced to come out in the screening process. So, for example, for women who are recalled to assessment, trans women who are recalled may be asked to provide additional information about hormone use or implants. So while we don't directly ask about sexual orientation or gender identity, it is likely that this information will become apparent in the screening and assessment process. Earlier this year, our coordination unit was awarded Rainbow Tick accreditation, which demonstrates our commitment to diversity, inclusion and accessible screening for LGBTI communities. And it also shows that clients will receive inclusive services and be treated with dignity and respect, and that we do meet comprehensive national accreditation standards in our commitment to managing safety and risk. This photo here was taken, obviously, this month at a Rainbow Rose session that we held at the Rose BreastScreen Clinic within David Jones in Melbourne. We allocated times, 2 group booking sessions where women could feel welcome and safe and have a screen, ask any questions they wanted to along the way, and we had really great feedback from the women. So we know that hormone therapy increases breast cancer risk. However, there's limited evidence about breast cancer risk and suitable screening for transgender women. At BreastScreen Victoria, we recommend screening for trans women, so males who are transitioning to females, who have used hormone therapy for more than 5 years. And for trans men, we recommend screening if chest surgery has not yet been undertaken. I have more information around this on the table at the back as well. Go back, yeah.
So with trans survivors that are already in their youth and they've started hormone therapy now, they're going to be, have been on it, say, 20 years by the time they hit screening age of 40. Do you screen them earlier?
No, we wouldn't screen earlier. I mean, I guess that would be a conversation that would be had with health specialists along the way anyway, because of that increased risk. But in terms of screening, again, they'd be welcome from 40, but they wouldn't be eligible earlier than 40. So what we do see in the data is that participation in our program varies according to socioeconomic disadvantage. So 52.5% of eligible women in the lowest SES areas currently screen, so 52.5, versus 55.3 in the highest socioeconomic areas. And the incidence of breast cancer increases with socioeconomic status, and we're not entirely sure why this is. Theories include reproductive factors, so we know that not having children, as well as the age in which you have your first child, impacts breast cancer risk. But also lifestyle factors and remoteness of residence. So women in urban areas obviously have more access to breast screening in the first place. Women from lower socioeconomic backgrounds experience a higher mortality rate, potentially due to being diagnosed at a later stage. Specific barriers to screening that have been identified in low socioeconomic groups include perceived costs with screening and diagnosis, patriarchal cultural pressures to participate in roles such as caring or cooking or housekeeping, pressures from the inability to take time off work, job insecurity, and low wages.
What do you mean by perceived costs?
People think there's a cost when there's not.
But there is a cost in some places.
So for BreastScreen screening and diagnosis, there is no cost. I mean, there's certainly cost associated with travel, for example, and if there's accommodation that's also needed. But in terms of the screening process, up to the point of diagnosis with BreastScreen, there are no costs.
I thought there was in some areas.
Not with BreastScreen. Privately, if women choose to screen privately, there is. Yeah. So an example of some engagement we did with this population group was that we partnered with the community support Frankston, which are obviously a community organisation within Frankston, which is a low socioeconomic area of Melbourne. And we really worked to increase participation within their client group. So we ran some staff training for their caseworkers and volunteers on BreastScreen's key messages. We attended their open day as part of National Homelessness Week, and we spoke to the client group about breast screening and breast awareness. We then collaboratively developed some specific and targeted promotional materials. So brought it back to have an illustration rather than a photo, for example, because not necessarily all photos are all representative of all women. We also really promoted the phone number to make an appointment rather than the website, because not everyone had access to the internet. We organised a group booking at the Frankston Clinic, and we organised transport to get them there. And in the end, we had 9 bookings made at the open day, which was just fantastic. And I guess the key to the success of this project was that cross-sector partnership to ensure that we addressed a lot of the barriers that this population group face in terms of screening. So now that we've looked at each of the 6 identified under-screened population groups, I wanted to loop back to what we know about the motivations and why people do screen. So the non-returners survey that I mentioned earlier, that looked at reasons people didn't return after their first and second screens, provided 3 recommendations of areas that we can focus on. And this includes improving information and reminding people that they do need to screen. Education is key. from the report I can quote that after reading that a biennial breast screen is the best way to detect breast cancer early, 1 in 2, so 53%, are more likely to return. Supporting access to screening. So suggestions that we had come back to us were having more locations, more accessible opening hours and screening hours, and increasing the reminders that we send out to women. And also prompts to book. So critical points of influence when we interact with women. We should leverage these to convert lapsed women, so women who have not returned to the program, to return. Primary healthcare ties into 2 of these key recommendations. So educating patients about why regular breast screening is so important for ongoing health and wellbeing, but also ensuring there's information accessible in the clinic. There are posters in your packs, but I've also got bigger versions of the posters at the back of the room. Feel free to grab as many as you need. We know that a GP recommendation is vital in ensuring women participate in the breast screen program. While women don't need a referral from a GP to attend, it's that recommendation from a trusted health professional that we know is key in their decision to screen. So, some strategies that we can look at to implement to increase participation. It's really important to identify and discuss any factors which may help women make an informed decision about their decision to screen. So, clear communication in ensuring women understand why breast screening is important, and really working with them to address some of the barriers that they face to access the service. The common thing you'll probably hear is a lack of time and concerns about cost. You can reassure them that it takes 10 minutes and it's free. GPs and primary healthcare play a really important role in educating women aged 40 to 49 about their decision to screen and the appropriateness and effectiveness of breast screen for that age group. Explaining the need for compression. So the reason we do compress the breast when we're taking images for breast screen is for 2 key reasons. It's to reduce movement so we can get a clear picture, but also to reduce the amount of radiation that the woman is exposed to. So reassuring women about the reasons why we do that, and also that they can tell the radiographer to stop if it becomes too painful. It's important that we encourage women to be familiar with the normal look and feel of their breast tissue throughout their lifetime. We know that breast tissue changes from puberty, pregnancy, breastfeeding, menopause, weight gain, weight loss. It's always changing. So that's why it's important for women of all ages to be familiar with what is normal and what is potentially not normal, and something that should be discussed with their GP. We have GP recommendation pads, and I've put one in the packs, but again, I have more at the back of the room. So while a referral isn't needed, this recommendation pad can provide that extra prompt. It has booking details, it has eligibility details. It means you can write down where the local clinic is, rip it off, and hand it to the woman. You can use your clinical audit tool to identify new women who have never screened in the program before, or those who are lapsed, so are due for a screen and haven't yet booked. Yes.
Because often with NCAT, it only takes out of the medical software if you put the information in the right spot. So, in the scripted text, we use medical director. Am I correct in saying that you have to put mammography in the scripted text to get it to pick up from MCAT?
I'm not sure. Let's talk about this afterwards.
All right.
Yes.
Sorry if you do it fairly right.
No.
It's just like cervical screening. It needs to be under the women's cervical screening tab result. Otherwise, it doesn't go. But I'm not 100% sure about MCAT.
Yeah, okay. Neither am I. And I think this is really important. So I'm going to find out and we'll chat about it later. Oh, really? Okay, fantastic. Excellent. You can set up a clinic promotion. So October is Breast Screening Awareness Month. You can set up a table with some flyers, some postcards, some bookmarks, pens. I've got some examples of stuff at the back of the room. Please feel free to grab some. or something around Mother's Day, something around New Year's resolutions, whatever it may be. You can get a bit fun and creative. We provide support for patients, so we have a number of resources. Our website is a very comprehensive tool in terms of providing information about eligibility, accessibility, where our clinics are located, that kind of thing. In the same vein, our website has information for health professionals, including information about online learning modules for more information. So, of course, the Western Victoria Primary Health Network has the Health Pathways module. Cancer Australia has collaborated with both RACGP and the Australian Centre for Rural and Remote Medicine to develop some online modules for primary healthcare. The RACGP has 2 modules that are free for members, and there are 6 free online modules for the Rural and Remote Medicine course. How much time? Little time? Yeah. That's all I wanted to cover. I hope that provides a useful basis in which to explore some of the barriers in more detail. As I've said, there's information in your packs. There's only one of everything. There's more of everything at the back. So if you do want to take more posters, brochures, all that kind of thing, please help yourself. And I could take questions if that's useful.
A side thing that BreastScreen could promote, because I mean it's women, it's the active women that are being breast-screened and probably aware of it, but just to mentioning about men with breast cancer as well. It's just a non-event.
Yeah, it is.
Really hard.
Yeah.
I know, even the pink days they have a cricket, if they're a captive audience, it's hardly ever mentioned that men can get breast cancer.
Yeah, it's true. I mean, for our program, men aren't eligible, so that's certainly why we, that's why we, and
even just a little tag on print, as a woman who is being screened for this, just be aware your husband, partner, friend, son, anyone can get breast cancer.
Yeah, absolutely. Because also the risk factors can be much the same in the sense of that strong family genetic history, lifestyle, those kind of things can lead to breast cancers in males as well.
I know, just from a personal experience, I'm sitting in Ballarat Hospital the day of the pig test with my husband waiting to go into breast cancer. How big we have it, and it hasn't even mentioned. Hasn't even mentioned. Just really disappointing.
Yeah. Look, I mean, it's certainly something we can, we as BreastScreen can look at because, like you said, captive audience.
Just a little. And it was amazing. My husband's been very forthright in coming out. He's a local barber, so he sees all of it. And talking about it. And it was amazing the men that said, give me love, you could get breast cancer.